manual or inefficient way of claim processing. Still a lot of paper-based or even the paper, even the digital checking the claim manually. That's also delay the payment to the hospital providers. And also limited analytical capability for the large set of data in the standard strategic purchasing, that especially like a DLG or capitation performance-based financing, we need to analyze a large set of data quickly to see the performance and then also costing of the healthcare services. And also weak monitoring for the expenditure and potentially leading to the fraud. So we also need to be careful how the claim is submitted and used for the reimbursement. That's also important area for monitoring. So AI matters because it's enabled to shift from manual administration to more data-driven operation and decision-making. So this is not just automation of claim processing or analyzing data, but also improving the health financing operation and improving efficiency. That is the ultimate goal for this AI for health financing. And ADB is supporting the several countries on this digitalization of health financing operation. And now we did the initial first, second phases for the landscape assessment and also case studies, identify new technologies. And now we are doing the pilot testing of the AI in some specific countries on the health finance operations, like Indonesia, Philippines is one example, and we are expanding this in other countries. And we got the support from the high-level technology fund and EAKPF, it's Korean Fund for Knowledge Management, to identify new technology that we can support in countries. So we have done the case studies, landscape assessment, gap assessment, and then innovation challenge to identify new technologies, and then pilot testing. And then we are concluding the first 3 phases of this technology, TA. So for the digitalization of the health financing, AI is only one part of it. We cannot just introduce AI technology or tools to the health finance operation from beginning. We need step-by-step approach. So for example, first of all, we need to digitalize the health financing operation, like claim processing from paper to digital, and then also connect the data, interoperability of the health financing data across the ministries and also the local governments and also health financing funds or purchasers. And sometimes in country have a mixed financing methods, not only public. We also need to make sure the connection with the private insurance data and also private health providers, not only public. And then, of course, once we have a good quality of data, that we can start the advanced analytics of the health financing data for future and also ongoing use of the health financing operations. Then I think we can introduce AI application at this stage. And then finally, that we can use AI to improve the strategic purchasing or more data-driven decision-making for the current, but also future health financing operations. So we see that AI is enabler, not just a standalone solution that we should introduce to the country. So as you see that the health financing operation, there are multiple data involved. So claim data, utilization data, provide contraction on the price data, and the data from adjacent government system and actualization, the policyholder, and even applications like mobile app or website data as well. So there are multiple data should be gathered and get connected for the advanced analytics, for the more, the descriptive, what is happening now to understand the situation, but also prediction, what is likely to happen in the near future, and also more prescription for the future sustainability of the health financing. So once we have a sufficient data and with the support powered by AI, we could also prepare modeling for the long-term financial stability of the scheme. That's also an important area we'd like to explore for the future assessment. But we need a good quality data and sufficient. That's, I think, the basis of the introduction of the AI in health financing operations. So in the core case for the health financing operations, we can use AI for automation of the claim processing. So quick review and then quick decision whether we can accept or we need to get the clarification from the providers, or also claim verification or automation decision as well. And then, as I mentioned, the fraud, waste, and abuse, that's also the area some insurance companies or insurance funds are already started for the part of the operation. And then, of course, as I mentioned, the operation, future expenditure forecasting is also an area that we can also help. And this is just one example of the automation of claim processing where the AI can be used. So this is a step 1 to step 6 and how the insurance operation to receive the claim and then the initial approval and then hospitalization and treat patients and then final claim assessment and reimbursement. So across these operations, usually the step 3 in the initial submission of the pre-authorization approval and also the final authorization of the claim reimbursement timing that AI can be used for the quick assessment and decision. And then, of course, as I mentioned, the strong data it's critical. Otherwise, it's difficult to operationalize AI, not just pilot testing. So the 4 critical requirements: 1, interoperability across health financing system, and strong data governance and institutional arrangement, and also adequate legal and regulatory framework. That's also critical. And we face several challenges that the government and agency wanted to introduce AI, but their internal institutional regulation is not allowed to use AI because of contractual arrangement or data security, data protection requirements that the vendor cannot access the data, so that the AI cannot learn the data sets to improve the assessment. And of course, we need the human capital and change management to make the AI tool is acceptable and usable for the staff working in the institution, but also health providers. They also ultimately use these technologies. And of course, the data privacy, security, and algorithm transparency and accountability is also critical. So it shouldn't be the black box of the decision. So it should be the explanatory to the especially provider who received the rejection of the claim, for example, and also bias and the exclusion risks and the sustainability beyond the pilot funding. That's also we see difficult to sometimes continue this application because of the subscription issues and the fees. So, and finally, the ADV is supporting our country clients to introduce AI based on the initial assessment, and also potentially we can include as part of loan packages so that we can help the country to use the new technologies as part of the health financing operations. And not just a technology agenda, that's also policy, regulations, and financing agenda. So that we need a big health finance. It should be the part of the health financing reform, not just a technology discussion. And of course, not only the high-income country to teaching the AI technology, but also peer learning from the similar level of countries or advanced, similar level, but also a little bit advanced country would be useful for the learning for this agenda. Okay, so thank you very much. So I'm happy to handing over to moderator to introduce the 2 case studies and also have a moderated discussion after that. Thank you.
Thanks, Akihito, for opening our session 6. Now we will hear India's country experience on AI and health financing. This will be delivered by Mr. Rudy Kurniawan, Lead of Innovation and Health Financing Team at the Center for Data and Information Technology of the Ministry of Health, Indonesia. Please let us give him a big round of applause.
Thank you. Good morning, everyone. Today, I want to share about the digital healthcare in transformation journey in Indonesia, include the financing system in Indonesia. And this is Indonesia. As you know, that Indonesia is a very big, and we have so many numbers of islands and also we have a population about 279.9 million. And this is our digital transformation journey. We have in the 2021, we have a COVID focus and blueprint preparation for the digital transformation. And also in 2022, we have set up platform standard regulation and initial integration. In 2023 until now, we have integration rollout and COVID app transition after the COVID pandemic. And this is our blueprint of digital health transformation strategy. Right now, we currently using for the 2024 to 2029, but this is for the 2024. First is we integration and development of health data system. And the second, we integration and development of healthcare application system. And the third is we have a health technology ecosystem development. And this is achievement of the health digital transformation from the 2021 to 2024. We have a standardization and integration of health data, and we have application integration to simplify health service processes and also health technology ecosystem. And this is our new digital health transformation strategy. We have four missions. The first is about build a connected, secure, and sustainable digital health ecosystem, inclusive and user-oriented digitalization of healthcare services, and utilizing data for decision-making, and also fostering a digital health innovation and collaboration ecosystem. And for the digital health transformation strategy and health financing, we have support from ADB. Thank you for ADB. First is about integrated health financing. We have e-claim integrate with the BPJS, our national health insurance. After that, Pak Setiaji will presentate also in the panel discussion about integrated health financing. Also, we have integrated information system for national health account. So for we have for the arrange the national health account, we have integrated information system for national health account. And this is like in our mission, the first, the second, third, and fourth, we support also the health financing to integrate the data. And this is our regulation. We have a regulation to data integration to the Satu Sehat platform. To integrate, we have a concept of interoperable. We have data integration to Satu Sehat platform. Also, we have sanction for especially to implement the electronic medical record. Also, we have a data standard and security. We have ICD, SNOMED City metadata, also Loing, Fire, HL7, ISO 27001. Also, we have for the research and policy. This is Satu Sehat. Satu Sehat is a health technology ecosystem that provides integrated and high-quality healthcare services. This is our Satu Sehat. We connecting and empowering the entire health system ecosystem and users, and we make a society in there with the Satu Sehat platform as a health information services hub. And this is our interoperability. So like Aki mentioned about the interoperability. We have the ability of data to be shared and exchanged between interacting electronic system. So we start with make it all data is electronic, especially for the electronic medical record. And we make the interoperability. With this interoperability standard, we have terminology standard, we have data exchange standard, we have privacy and data security standard, also identity standard. And this is our achievement in early of this year. In January 2026, we have integrated facilities with 91% of primary care and 95% of hospital we have integrated with the Satu Sehat. Also, we have professional licensing and efficiency for human resources and health. Before this, for the STR is a license for the practicing of the health professional in Indonesia. Before is 14 days to make a STR. Right now we have maximum 5 days. Also we have patient impact and services about 270 million patient integrated to Satu Sehat. And how about the innovation of the health technology? We have health technology innovation to improve health services. We focus on utilizing technology innovation to improve quality of health services. We start with biotechnology. We will make the precision medicine. Also with the AI or artificial intelligence. Also we try to use the robotic. So also we have National Committee for Artificial Intelligence and National Robotic Technology Committee in Health Sector. This is a AI Health Committee. AI Healthcare Committee, we have from the researcher, doctor, healthcare industry, healthcare practitioner, government. We have 3 tasks. First is about produce AI for healthcare regulation. The second is build AI healthcare key use case. And the third is about global healthcare AI hackathon. This is ethic and principle. We also adopt from the WHO about ethic and principle of the AI for the healthcare sector. We have Indonesia National Artificial Intelligence Regulation. Right now we have circulator letter of the Ministry of Communication and Informatics number 9/2023 about this one. And also we have a roadmap to make how to build and implement the AI for the health sector in Indonesia. This is AI healthcare use case. For the genomics, we have machine learning to study DNA characteristic of cancer cell, oncology precision AI therapy. Also, we have healthcare imaging AI, especially for the pathology and radiology. Also, we develop large language model to analyze health resume and recommendation of free health checkup report. This is our hackathon. We have Indonesia first hackathon AI in 2025 with participant of 278 teams from 10 countries. Also, we have a priority of the disease about AI. First is about stroke, CVD and diabetic, tuberculosis, and also stunting. This is our priority of the implement AI, and this is the winner of the our AI hackathon. That's in the 2025. And this is after the hackathon, we send the winner of hackathon to this sandbox. We have a sandbox expression, we have a sandbox, regulatory sandbox, industrial sandbox, and innovation sandbox. With product is about recommendation and regulation, and innovation and utilization expansion, especially for industrial sandbox, and health innovation for the innovation sandbox. In Satu Sehat is our innovation answer challenges and also provide solution for every part of society. So right now, Ministry of Health call for collaboration with all stakeholders, also about especially for about knowledge and expertise collaboration. We have resource collaboration, also implementation collaboration. Maybe that's all from us from the Indonesia. Thank you very much, and back to Anya. Thank you.
What a wonderful presentation. We're really impressed on how far Indonesia has gone with their AI. Now we move to Uzbekistan's country experience to be delivered by the Chief Specialist of the Department of Budget, Formation and Execution of the State Health Insurance Fund of Uzbekistan, Mirseya Buk.
Good morning. Good morning, and thank you for the opportunity to speak today. Akihito, unfortunately, I do not have an orange tie, as you. I will present the experience of Uzbekistan in linking health financing reform with the emerging use of artificial intelligence. I will not cover use of artificial intelligence within healthcare services of our country. Let's start with the current reform path in Uzbekistan that can be understood in 4 broad stages. The first important milestone was in 2018, when Uzbekistan launched a comprehensive reform agenda and placed health financing and primary healthcare transformation at the center reform, in line with universal healthcare principles. In 2020, the Sirdarya region of Uzbekistan pilot marked a very important step. And in the same year, the State Health Insurance Fund was established as a strategic purchasing agency, and the first practical elements of contracting and payment reform and digital solutions began to emerge. In 2024, especially after Presidential Resolution 311 approval, reforms started to scale up, and importantly, in the same year, the National AI Strategy was approved, giving healthcare a recognized place among priority sectors for AI development. Now, in 2025 and 26, Uzbekistan has entered a phase of consolidation, and but the phase also makes visible remaining gaps, especially around real costing, payment rules, financial protection, and the governance needed for digital transformation. The new law adopted in 2026 on relation arising from the use of artificial intelligence establishes an important principle. AI system must not harm people, their health, dignity, rights, or freedoms. It also makes clear the legally significant decisions affecting human rights cannot rely only on AI conclusions. As you can see, Uzbekistan has made significant progress in service coverage. The Universal Health Coverage Service Index has risen strongly over time from 55 to 75. However, better service coverage does not automatically mean strong financial protection. Households still face substantial out-of-pocket spending, especially for medicines. This is why the next phase of reform must go beyond expanding services. It must also reduce the financial burden on households. One very practical example of financial protection is the medicines reimbursement program introduced in 2022. At the same time, this is also an area where AI can be especially useful. AI can support expenditure tracking, identify unusual prescribing patterns, forecast budget needs, and help target reimbursement more effectively. Over the last years, the burden of household expenditure on health is improving, which is encouraging, but the issue has not disappeared. Financial hardship due to health spending remains a real concern to many families. At the same time, Uzbekistan has set an important strategic objective to raise public health expenditure to 5% of GDP by 2030. This creates a stronger fiscal foundation for universal health coverage. Now I would like to turn to the digital architecture, because no serious AI use in health financing is possible without digital foundation. As Eduardo Banzon mentioned earlier, to adapt to the existing context. Today, Uzbekistan already has several information system components in place, and the architecture you can see is evolving towards a more integrated SHIF, State Health Insurance Fund ecosystem. The planned direction is towards stronger interoperability, better analytics, and the inclusion of dedicated AI and payment modules. So, digital foundation already exists inside State Health Insurance Fund, and AI opportunities can be mapped directly onto existing operational modules. For example, MedExpress covers clinical records and episodes of care, including the future DRG environment. In this area, AI can help with coding support, claims review, and prediction of severity of cost, and so on. So the important point is this: Uzbekistan does not need to start from zero, but AI can be introduced as a layer on top of existing functions inside SHIF, where it can solve concrete operational problems. This slide, sorry. We missed one slide, I think. About DRG hospital payment, that is one of the key priorities for our reform, hopefully with ADB and WHO support. And the development and implementation of the DRG system is not only a technical payment problem, it's a major institutional challenge for us that required better costing, better analytics, and stronger control, and that's exactly why AI can be useful here. In our view, AI implementation in health financing should always be staged. The first step is assessment and planning, the second step is piloting, and the third step is scale up. And there are several major risks. Many of them discussed here yesterday. Each of these risks requires a practical response. So, good governance is not something added at the end. It is what makes AI acceptable and usable in health financing in the first place. Okay, and now my concluding message: AI in health financing should be judged on these three tests. First, does it make the system fairer? That means widening effective coverage, identifying hardship risks, and making entitlements easier to use. Second, does it make the system smarter? That means starting where the financing payoff is clearest: medicines, referrals, claims, and of course strategic purchasing. Third, does it make the system safer? That means human oversight, appeals, open standards, and regular equity audits. If these conditions are met, AI can support a health financing model that protects people more effectively while giving government stronger tools for purchasing, planning, and accountability. Thank you very much for your attention.
Thank you, Mirsay, for that presentation from Uzbekistan. Now we move to our panel discussion. It will be moderated by Akihito from ADB, and we're bringing you back Annie Chu from WHO. We will be having our panelists from different institutions who are very relevant in our session 6 today. 2 of our panelists are joining us virtually, and 2 are here with us today. So please let us welcome our panelists who are on live today: Zaurav Bataray from OpenEMIS and GIZ, and Pak Setyaji from BPJSK Indonesia. So can we ask our tech team to show them on screen, and let's say hi to them. Can you hear us, Saurav?
Yes, absolutely. Good morning,
Can you-
everyone.
Okay, thank you. Can you greet us? Good morning, Pak Setyaji.
Good morning.
Okay, at least we're all ready for our virtual panelists. Now we move on to our panelists who are here with us. May I introduce to you Zhang Yuangzi from People's Republic of China, and from CNAG Solutions from the Philippines, Francis Uy. Let's all give them a big round of applause as they come on stage and join us. And now I hand you over to Annie and Akihito.
Okay, so thank you very much everyone for joining this session remotely and also in person. So we had two presentations of the Indonesia and Uzbekistan. One is more data integration on the health financing using the Sasehat platform. And then another one is also the Uzbekistan initiative, how the building the health system, the health financing data system can be potentially used for the AI in the next step. So first of all, that we'd like to ask a question to everyone for the reflection from the country perspective, a country presentation, and also how that's going to be applicable to your country and or your work. And just before starting the session, I also acknowledge that we and ZIZ, Open IMIS, and ADB working together for the workshop and also e-learning module of AI for health financing that we started last year. And we had a workshop in Istanbul and also online, and also webinar on the USC Day. And both the Uzbekistan and Indonesia were part of it. And we are keen to expand this learning and peer learning this year, coming years. That's also important knowledge sharing and also learning platform for us. So let me start with Opnamis, Sarab, for your reflection, and then maybe followed by, the Pak Sejat. Over to you, Sarab.
Thank you, Aki. Yeah, looking at also the presentations today in terms of what are enablers for AI and what really helps move this forward. It's apart from a lot of things that we generally talk about in terms of governance and policy. Of course, those are required. But one of the things that in our experience at OpenIMIS and GIZ, working with various countries, we've come to is really one of the key enablers is really having clearly defined processes in health financing operations within the organization, and ideally digitized as well, because we need to know within programs in terms of how business processes need to be clear in terms of where data flows, who does what, because that, for example, in claims, what are the steps in claim submission, where do reviews start, in what order. So when these business processes are well documented, you really get the clarity on where the bottlenecks are. No, and that is key to identifying where AI can help you as well. So it's really at the foundational level, we should have some business processes well defined, and unfortunately it's not always the case. No, there's a lot of operations going on without very clear business process documentation. And towards the digitization of it, the second enabler that we see is again, and Aki, you mentioned it in your presentation as well, on data and availability of not just data, but structured and consistent data. And here, let me give a quick example of one experience that we had in Nepal when implementing an AI-based claims adjudication module in OpenIMIS there. We came to a point where the model was, it was a model developed for Nepal, but the model suddenly starts started decreasing in performance after a particular day. It was very inconsistent. Like at one cutoff date, the model's performance decreased. We investigated further and found out that that date was when the COVID lockdown started in Nepal. And that meant that the claim reviewers whose manual review data the model was trained on, these reviewers went home and reviewed the data from home office. And that meant that they could not communicate with each other on certain cases. So that really decreased the consistency of the data. So data is important, structured and very consistent data is important. And then the third enabler, I would say, it's really on really focused identification of the correct use cases. We sometimes have the tendency to say, okay, well, AI can help us in a lot of ways in health financing. We want AI to solve every problem that we have, but I think an enabler is sitting down with the organization and identifying small, very intentional use cases where it can be like, even within claims adjudication, what is the problem that we want to solve? And that really helps. So in summary, yes, exactly. Our experience has shown that defined clarity, consistent data and really getting into the cases is very important. Back to you, Aki.
Thank you very much. The structured data is critical for this AI application. Yeah, so let's move on to the Park chat. The BPJS case is already using AI. So that's also the same question, but what is an important enabler for you and the BPJS to introduce AI in your health finance operations? Over to you.
Yeah, thank you. Good morning, colleagues, and also esteemed panels. Yeah, thank you for having me today. Apologize, cannot present offline. Yeah, at BPJS Kesehatan or National Health Insurance, yeah, we are managing one of the largest single-payer health insurance system in the world, covering over 281 million lives, more than 98% of Indonesia's populations. Yeah, to give you a sense of the scale, we process over 1.4 million transactions every single day across 27,000 healthcare providers. Yeah, we are no longer just a health insurers. We are a massive data organization managing roughly around $12.5 billion in annual claims. At this volume, AI is not a luxury or a pilot project. It is a fundamental necessity for financial sustainability. However, our journey has taught us that AI is only as powerful as the foundation of sits on today. Yeah, today I will also give you some experience and some use cases we already initiative. Yeah, in my experience, there are three most important enablers of responsible AI adoption in health financing operations. First, data integrity and interoperability, as I mentioned by earlier panels, about data standardizations, interoperability, integrity is very important. At BPJS Kesehatan, we operate under the principle that AI is only as accurate as the data that train is. Therefore, the primary enabler is not the algorithm itself, but a data standardization. Without seamless interoperability across thousands of healthcare facilities, Rudy already mentioned about the Satu Sehat have standardized using the flyers in SBGs, many things. AI operates is in silo. We must ensure a unified data limits to move from fragmented information to a high quality. We need to develop single source of truths that can power meaningful of AI insights. And then the second thing is trust and transparency or explainable AI. For AI to be integrated into health financing, specifically in automated claim adjudications, it must be explainable. We need to explain the models, what we need to develop, and then what's kind of data used for the trains and many things. We cannot have a black box system where claims are rejected without a clear rationale. We need framework where healthcare providers clearly understand the logic behind AI-driven decisions. Pulling this transparency is the only way to establish long-term trust between the payer and also the providers. And then the last about the regulatory sandbox. Innovation often moves faster than regulations. We need a regulatory sandbox, a safe policy environment that allows us to test AI models, such as advanced fraud detection tools, on a limited scale. We have developed some models for detection for fraud and many things for risk profilings and many things. We run first in the sandbox. We work closely with the Ministry of Health to using the sandbox regulatory as mandatory for new innovations. Actually, this is a safe to fail. Space enables us to validate accuracy, address ethical concerns, and measure impact before we commit to a full-scale national implementation. Thank you.
Thank you very much. In particular, I think trust is important. Without the trust and transparency, it's hard to ask the provider to follow these new new tools. So the next is Francis, that you're working for support for the DOH and Fair Health on this business population for the digitalizations. And from your experience, what's going to be the important enabler for the AI applications?
Yes, so I'm wearing, I'd say, two hats. I'm doing work with the WHO in creating a country reference architecture for digital public infrastructure for health. And inside of that, we're looking at 7 health goals. We're creating a country architecture for health financing in particular. We were looking at public financial management and also universal health coverage and ensuring that we have the right designs for that from a process, from a data, and also from an AI perspective. And my second hat is working as a health financing architect for PhilHealth, as well as supporting DOH in nutrition work in some of our health architecture aspects. And so first, a reflection on the talk from Dr. Maisia, and also the talk from Rudy, is that when you think about AI, it really is a component of your digital transformation or digital health transformation. It isn't a new thing. It isn't something that you have to think in isolation. And so the work that has been done on policy, on enablement of security, of data privacy, all of those are going to be important in ensuring that all of these new emerging technologies, and AI is just one of these things. In the future, we're going to have a new one. They're all part of the same ecosystem of ensuring that we have the right framing skill sets and aspects related to that. And so from an architectural perspective, as I look at, also reflect on the talks yesterday, what I can really see is that when we look at this AI and digital health as a capability, we need to look at those 5 core areas that were highlighted yesterday and also were repeated this morning. One is ensuring that we're very clear on what the clarity on what the goal we're going to drive that will really make a difference to the key stakeholders. Second is understanding of the business architecture, and Aki shared some of that from a health coverage perspective, and we need to make sure that that's very clear to key stakeholders so that we know where do we put AI, where does AI really make a big difference. Third is org readiness, fourth is data readiness, and fifth is a technology readiness. And I was initially thinking, you know what, for AI, data readiness is the most important. But what I realized from listening from everyone, actually, you need all 5 of those. They all have to exist in your pilot, and they all have to make sure that that is going to be your sign for effectively scaling this. So that's what I have seen is going to be effective for us from a use case perspective, and also as a reflection hearing from the talks that we've had yesterday and this morning.
Thank you very much. So let's move on to the final reflection from the Chinese perspective. Dr. Zhang, over to you.
Okay, good morning, everyone. I represent National Healthcare Security Administration of China. The NHSA was special one in Chinese government system. It's parallel to the National Health Commission of China. And the NHSA report directly to the State Council of China. And we manage China's basic medical care insurance, which is also the largest medical care insurance in the world. And today, I want to share a specific area that we focus on lately, our institution focused on lately, that is AI plus medical imaging. And I want to first answer the question, why do we concentrate AI on medical imaging? There are 2 key reasons. One, to fix the unequal access to doctors. As we discussed yesterday, top radiologists all around the world always stay in big cities. Rural patients have to, who looking for diagnosis have to travel far or risk misdiagnosis. But AI can change this. AI is changing this. Nowadays, by using AI, at least in China, many patients in rural areas could get diagnosis as accurate as in big cities hospitals. And I think that would promote health equity as we discussed these days. The second reason is, I think it's more important, that is AI at medical image could transform medical capability. Data like CTs and MRIs are structured and cleared, which is perfect for AI training. By studying millions of anonymous AI, information from the patients of the images, AI can see many tiny disease signs which human eyes might miss. By analyzing these patterns, AI in imaging could help us to develop new understanding of disease and better diagnosis methods. It could take healthcare to a completely new level, as we assume. That's what I want to introduce first. Thank you.
Thank you very much. Yeah, that's diagnostic, one of the area that AI can be used to improve the quality and the diagnosis sensitivities. That's true. That also potential cost implication of the benefit package design. That's also another area we also need to see how the AI potential impact on the benefit package on this. So let me handing over to Annie for the follow-up questions to all the panels. Over to you.
Great. Thanks so much, Akihito. And good morning again, colleagues and panelists. So I think it's a good point that Mr. Zhang had made about both in terms of the quality of services, but also in terms of equity in access. And really, we want to also see and hear from country examples about how AI has also supported you in having that increased access, especially in limited resource settings. So if we can turn to our colleagues, our panelists online, in how to make AI work in these low resource settings and constraints, and whether or not and how we manage in terms of some of these imported models for local adaptation and to prevent, for example, failure, or how to manage those processes in the different innovations. So I'll turn to first Sarah for an open IMIS. If you can share some country examples in terms of how AI has been able to work effectively in these limited resource settings. Thanks.
Sure. Thanks, Annie. When in our work with OpenIMIS, particularly the case that I talked about before as well in Nepal, but also in other countries as we move along with particularly developing a model based on, well, an open source model. So that has been a very key aspect where we've been developing a module within OpenIMIS, also open source, that countries are able to use to introduce AI into their insurance processes. And there we've seen that having access to such an open source technology, which provides the base. So for model development, that the initial investment is already there. That already provides, particularly for countries in the low and middle income country context, a head start into delving into the use of AI. So what this means is that we're trying to work with, trying to have modules or AI models that apply to various scenarios. For example, claims adjudication using standardized interfaces. So we have what we call the HL7 FHIR standard for claims. So anyone with an HL7 FHIR claims resource within their operations could take advantage of the AI model to use. And also having this provide sovereignty to the country as well, that the model can be implemented and should be implemented, let's say, within the digital infrastructure of that country. You train it using your data. So our experience has been providing the AI technology, the model there, but it's trained on the local data, which then can be, and once that machine is trained, it can really help in the processes. But at the same time, the one thing that we've been talking about this whole session is all of this is very dependent on the availability of structured, consistent data, and we just have to ensure that we have systems in place that are collecting this data. But once that is there, we've seen very good examples of countries being able to use AI technology much more easily. Thanks.
Great. Thanks so much, Saurav, to highlight that countries have been able to adapt these models and using the local data, as you mentioned, training the local data, but also a key reminder about those having those systems and the data in place and the importance of that in being able to adapt and utilize AI, especially in more limited resource settings. So now I'd also like to turn to Pak Setyaji online to also reflect on the BPJSK experience in claims processing, for example, and with Indonesia, given the large landscape and population coverage, especially in more rural areas or areas with lower access. If you can reflect and share with us on that. Thank you.
Yeah. Okay. Thank you. Yeah. I will give you also some figures here about the Indonesians. We have more than 17,000 islands, more than 40% inhabited. Yeah, so we have some issue about the limited access, especially in the remote area. So the AI, especially for diverse, live in the diverse, is very important. We need also to develop the AI models to run in the edge. It's mean offline. So we have some approach to develop the models, enhancing the models using the GPU. And then after we get the good results, especially for the sensitivity and also another numbers, after this we can run in the offline. This is what we currently using some approach. And then we have very lucky because currently some of the models is very low bandwidth. We can use the low memories. I heard from some articles today. The Google already finalized some tools, and then they can run on minimize the memories. And then the other side is also how we can fixing the data at the source to combat low data quality and also identity fraud. We use a biometric AI, face recognition, and also the fingerprints integrated directly within the national identity database coming from the Ministry of Home Affairs. This ensures data integrity at the point of care, even in areas with patchy connectivity, by using light validation models that can function with minimal bandwidth. And then also the another issue, or maybe we need to avoiding the imported model traps. We are very open to use another models coming from the abroad. We have some cooperation within the Pure AI, within the Analyze AI coming from the Australia, many things. The important thing also, we deliberately avoid black box models from developed nations that don't account for our local disease profiles or social determinants. Instead, we build local training sets For example, our AI-driven fraud detection utilize we utilize machine learning, for example, using the Queens as platform models, and then train on hundreds of millions of local claim records. And then after this, we have some result very good impressing, progressing. For example, almost 87% for accuracy. And then the other side is human in the loop. AI in our low resources setting as a co-pilot rather than a replacement, automating like 80% of repetitive administration tasks. So our limited medical verifiers can focus on the 20% of complex high-value cases. I think this is some of experience in Indonesia, how we can still use the AI in the remote area, and focusing, developing the edge computing AI in the remote area, and then how we can minimizing resources, for example, like memories, using the non-GPU like NPU, and then using the laptop, iPad, and many things. Thank you.
Thanks so much, Pak Setyaji, for sharing with us the many examples you mentioned about the use of AI and the different pathways and applications, especially in remote areas or low access areas in Indonesia, especially highlighting the offline models, as well as you mentioned fingerprint database at the point of care, and utilizing the local data to improve also the accuracy and other efficiency gains, which still can be done in remote areas. So thank you for that. And now we'd also like to reflect a bit and hear from the panelists on cross-country collaboration, including with private sector and the sharing of tools, models, standardization, and so on. So then I will turn to Francis to talk about your perspective in terms of what is the scope for sharing across countries some of these tools, these models, standards, for instance, as well as governance models that would allow for collaboration.
Yes. So the operating model we're looking at from an ecosystem perspective is a replication way, where we can learn from each other, we can get best practices without necessarily sharing maybe PII data across each of the countries. And we can use the existing groups that we have, either through ADB or the regional groups like AIHIN or PAHO, to be able to create that community. The idea here is if you're able to create a community of practice across different process owners or on the job, creating those AI use cases, then you're able to speed up the learning and be able to talk process owner, process expert to process expert. So for example, in the Philippines, I think of two use cases. One is we're thinking of implementing AI in improving the claims adjudication. We process thousands of claims every day. And if we put AI there, we not only improve the patient experience and the health provider level, but we also improve the fraud prevention. With AI, we know we can have automated checking of either falsified images of prescriptions or even verifying the signatures of doctors. And so those type of use cases that we're thinking about in the Philippines, I believe a lot of countries are already thinking about as well. And so creating a community of practice among process experts there will make a difference. Just quickly, the second use case we're thinking about is with the creation of the National Health Digital Data Repository, we're going to be sitting on a huge goldmine of data. And so for those de-identified data that we have there, we can then share again with other countries on what use cases we can look at to be able to harness that with AI. We're already doing a simple case of that one with PhilHealth, with our transparency server. We've linked the AI to the financial records of PhilHealth for the last 3 years. And you go to the website, you ask it questions, and it'll tell you data related to just what's in that database of, what's the percentage of claims, what have you noticed about that patterns over this time. And so if we are able to scale that from that mini use case to the entire country's health and health-related data, I think it's going to make a big difference.
Great. Thank you so much, Francis, for that. And perhaps those who are interested in this community of practice can further discuss over lunch. And then I'd like to turn to Mr. Zhang Also for this question, in terms of your reflections on potential cross-country collaboration and use of tools and models and so on. Over to you.
Okay, for international cooperation, I want to continue with my topic. I just mentioned AI plus medical imaging. This AI plan I just mentioned before. I want to talk about this topic with two questions: what and how. First, what? What have we done to the AI image project? I want to use two key actions. Action one: we move medical images to the cloud. In the past, patients in China who move between cities and provinces around China has to bear repeat scans because their image films are physical and they are heavy, they are unclear, and I think that happens in most countries. But nowadays, China, the NHSA, is now building a unified medical cloud system for medical image. Nowadays, people in China, they can share their physical image by authorize. They can authorize the qualified hospital in China can view their past, their history image, and many repeat scans and many billing RMBs that we see before now are saved annually, I assume. That's action one. Action two, we are hosting an AI competition. Just last week, we launched an AI plus medical imaging recognition competition in Guangxi, a province in South China, very near ASEAN nations. This competition will focus on some major cancers, and we expect more than 1,000 teams from top companies, top universities, and top hospitals will join this competition. Our goal is simple. We want to identify the best AI solutions and products from all around China, and we want it to promote health equity. That's my first question. What have we done? And how can we engage with us? I assume three keywords. Number one is to participate in the competition. That's an invitation for developers from all your region countries. The competition is open globally, and we welcome all the tech companies, hospitals, and universities from your region and other regions around the world can join this competition. And for more information about the competition, you can surf the official website, which I will give information to WHO. Okay. The number two is attend the final. This is invitation for all of you. The final of the competition will take place this October in China, Guangxi. And we invite you and your colleagues, all of you, to join this final. We can watch together the latest AI technology in application, and we can discuss our topics yesterday and today there with the enterprises, with the IT engineers, with the AI applications, I think. And three is adopt the existing tools. China has developed a range of practical and affordable AI tools. And AI tools, whatever in medical issues or other issues, is quite popular in China. And these all AI tools are very welcome to be shared. And I think we want to share China's experience, China's tools to our neighborhood, to the region countries. And we can try to them even in the one city or even one town or even one hospital. And we want bring more healthcare promotion to more countries, to more people. Thank you.
Great, thank you so much, Mr. Zhang. That sounds very exciting, and for this open call to colleagues to join in this global competition in China. So this has been a very thought-provoking panel discussion. So I'd like to thank all of our panelists. And as we close the panel discussion, we will open the floor to Q&A from the audience. So if there are any questions from the audience, please feel free to raise your hand. Yes, please.
Hello, my name is Hun Sang Lee from Right Foundation in Korea. It was really great to listen to many of the countries' diverse experience, really putting into practice and have some of the results already, and quite of a great insights coming from there. My question is, this was something that I was thinking about sharing in the final sessions, but I just wanted to maybe double check with like some of the panelists here. I think while there are like a lot of great big tech companies in the United States, I think in the one of the things that we have in Asia is the sheer size of the populations, and each of the country has quite of a great level of kind of health data infrastructure in various level. With quite of a level of achievement in varying degree of electronic data record system or EHR systems. And I was very impressed with how China was already putting in the cloud-based like imaging and also Philippines about data repository experiment that you are doing, but Philippines is doing. But how could we put this kind of work in Asia Pacific regional level practice so that we can have some kind of like selected regional focus of data repository where we can collect the data and store the data and, or in the cloud format, so that there can be some kind of collaborative learning that can take place while we can ensure the data security safely with the data sovereignty to be observed, but at the same time to put the sheer size of populations, the power of data put into use to strengthen the capacity of AI solutions that are actually coming out from many parts of the many of the countries in these regions to solve the health issues in this region. And I think it will take a lot of dialogue and discussion and financing, especially very complicated legal discussions and like some kind of like a framework that needs to be established to make it realizable. But I just wanted to listen from the country's perspective about the efficiency or benefit of approaching this this kind of approaches, not just in each of the country level, but in the regional or more of the federated level. Thank you.
Thank you for the question. Maybe I can answer that in two parts. The first part is on the knowledge sharing and reapplying best practices, looking at what are the developing and evolving AI tools out there that we can use at the Asia context, because it will have some difference in terms of how it's thinking. And really, if you think about AI, it's really just a baby. It's what, 2 years old baby? It's really just learning, no? And these things we're hearing about hallucination and model drift, it really just shows that it's just still learning and maturing. And so as it's doing that, I think us as parents in Asia can then kind of take care of it and grow it to the right maturity that we want it to be. So inside of this model, as I was thinking about, yes, of course, we have ASEAN, we have all of these political groups, so they can also look at the AE-HIN as potentially the vehicle, or even the ADB as the vehicle for countries to collaborate and to share their learning on this and any other emerging technology. I think that's the first thing. On the second thing is there's already a lot of work, like Paho shared earlier as well. There's a lot of work inside of allowing cross-patient data to go from one country to the other. So we've seen a successful case for the Kingdom of Saudi Arabia in the Hajj pilgrimage, because we have a lot of our Muslim brothers going there. They're now able to capture that data, that health record, so that if any of the patients get sick while in the pilgrimage, the data, the health data of that person, even if it's from Indonesia or from other countries, they can access that. So there are already use cases where that's been made possible. And so we can definitely do that, given the right mandate, given the right agreement of the countries on the value that the countries will get from doing so. So those are the two things to consider.
Thanks very much. Oh, yes, we have another question.
Hi, my name is Jong-Wan Park. I'm a director of Healthcare Data Development Division in Korea. So we are working on similar approaches and applications for deploying lots of AI applications throughout the whole country. One of the things that we are experiencing as challenges is actual physical connectivity at the site. And I guess this challenge is shared by lots of countries, not only for the islands, the countries with lots of islands, but also very rural town in the main continent. So I was wondering if you can share what's your approach about this. While I'm sharing ours, is as we are using satellites connectivity, which is very, very affordable, became affordable right away and nowadays. So I want to get to know what kind of approach you are using, and any comments on that, please.
Great, thank you very much for that question. I'm wondering if Pak Setyaji, would you like to also further detail in the Indonesia experience, and then perhaps some Mr. Zhang? Okay, thanks.
Okay, thank you for the questions here. It is challenging talking about the connectivity. I will give you some figures from 1,200 our primary cares. We still have some issue about the connectivity around 700. Not only about the electricity but also internet access. Because of that, last year we worked closely within the Starlinks. So they give me some good prices, the government prices for the health to deploy more than 300 satellite access. This is what we are currently doing to give the satellite access to this remote area. And then the other side, as I mentioned before, not only depend on the internet satellite, but also how we can move using the AI for offline mode. So they can run on offline, for example, in the tablet or in the laptop. So this is, we combine how we give the access internet using the satellite, and then how we use another approach to run the AI offline model in the edge. Thank you.
Thanks very much, Pak Setyaji. Would Mr. Zhang, would you also like to comment? Yes. Yes. Or
I want to have a brief introduction about China's application for AI in medical services. As I introduced, as government department responsible for healthcare payment, we possess a large volume of medical settlement data. Such data is strictly protected in accordance with relevant laws and regulations. But to apply the data for AI model training, we have conducted two actions. One is to desynthesize the data, and two is only to permit the model to be deployed on our local servers. And I think that's a data issue. The other is the models. China has developed a series of AI models, such as DeepSeek, which is quite cheaper than the models we had before. And we have very cheap energies like electricity. And the models are electricity is quite important for models. So energies and the data and the models, they together to help us to apply our AI solutions. Thank you.
Thanks, Mr. Zhang. So adapting to given the different contexts in regions to reach those areas in China. Thank you. Yes, please, another question.
Thank you, Annie. I'm Alvin Marcelo from the Asia eHealth Information Network. Francis has been mentioning about the AHIN network. And we'd like to, in advance of my presentation later, maybe some post-conference initiatives that we can do together. We can participate, the network can join the China AI competition. We have 11 laboratories from different countries. Some of them are here in the audience, Laos and Indonesia. And maybe merge the structure that's coming out from WHO on reference architecture and applying it into the innovative framework that the Chinese government is offering, something we can discuss maybe over lunch or after the conference. Thank you.
Great, thanks so much, Alvin. Any additional questions or comments from the audience, those who'd like to also share their experiences? No? Okay, we also have prepared, how much time do we have? Oh, 10 minutes. Oh, yes. Okay, we have 10 minutes. Okay, so then we actually have also prepared a Menti to seek the reaction and reflection from the audience as well. So we do have some time for that. So if colleagues can whip out your phones, you can participate. So this question is really about how do you feel about AI and health financing? We've heard from the different perspectives, and in this session, a lot of the benefits for the uses, developments in countries, and very interesting. Yes, so many colleagues sharing that really it's a necessity. It's where we're headed. We need to get ready for it. Those many feeling also optimistic, some neutral so far, and a colleague saying it's too risky at this stage. If any would like to share from the audience further reflections on that, please feel free. But I would say overwhelming majority thinking that it's a necessity and feeling very optimistic. Oh yeah.
So I just want to share two ideas. One is it's great people are optimistic and feel it's necessary. But as a kid, we have to make sure that we're always watching it. Now we're guiding it. We cannot let, at this point, especially for health financials, let it run the show. Always make sure that there is that person watching over and validating everything. And then make sure that there's learning of how much of the decisions or the recommendations are actually correct in terms of what the person actually said. So if those who are doing pilots, if you can get that data, I think that's going to be very, very material related to this work.
Thanks so much, Francis, for that. And then next question. Can move to the next question. What are some of the ways in which your country is using AI and health financing? We've heard from colleagues already on several uses in our region, also in other regions as well. What are some of the ways, and these are just some examples for the use of AI in health financing? Okay, so quite a few using AI in claims management processes, forecasting, analytics. Across the board, there's use across all of these areas: fraud detection, abuse detection, provider payment monitoring, some also using it for interoperability and integration across data systems. Would any colleagues from the floor like to share further about their use of AI in health financing? Okay, maybe we can always move on to the next question as well, but looks like quite a range across the use of AI. So next question, please. So based on the use of AI in your countries for health financing, what are then some of the current challenges that your country is facing or that you have been experiencing perhaps in your support to countries? And this is open-ended. So feel free, as we've heard, various key enablers that need to be in place or conditions that need to be in place. What are some of the most challenging ones in your experience? So we have data fragmentation, validation of data, validation of the maybe architecture, human resources and financing capacity building, having fragmented systems. So we see some patterns here: corruption, human resources and budget, workflow, validation again, poor infrastructure, lack of personnel, access to GPU, policies. So quite a range, I think, that we have discussed and also shared across countries. If we can scroll down a bit, I think there are some additional, yes, thank you. Okay, I see a lot of fragmented systems, data systems, silos, lack of integration across these wide range, human resource and financing coming across very strong as well. Legacy systems, which is interesting because those can be sometimes more challenging to utilize in terms of adding on. Okay. Integration issues, lack of digital literacy that we're hearing. And next question, please. So are there any additional key enablers that perhaps we have not discussed, or ones that you think would be really important in your situation that you would like to highlight? And this is open-ended as well, so please feel free to share. So I think based also on the reflection of the challenges, then we know that what are some of the then key enablers that would support the development in countries: political will, leadership, governance, commercialization of IP rights. And if colleagues would also like to share from the floor while you're answering this, that's also very much welcome. So as interactive as you would like. Change management, governance, regulation, ISO, IP permits, again, coming out, access to data, ethics, high quality data platforms, case identification, use case identification, and change management. So I think we see quite a wide range across the enablers, very much also in the governance space, but really as a colleague has also mentioned about the political will, the leadership in this space, and I see a lot of ethical considerations as well. So thank you very much for highlighting these various key enablers. We have just a few more minutes, so what we're going to do is just do a quick wrap up and summary. So I really want to thank again our panelists as well as our speakers. What we heard in the scene setting was really that there are these set of diverse challenges as well as key conditions by which across countries in our region and even beyond what countries are experiencing, what they have to grapple with, and then also what kind of pathway or process to support in addressing some of those challenges and setting the foundation for some of those conditions. And then we heard from our colleagues from Indonesia and Uzbekistan, really in some of these key achievements and really how to harness innovation, development, and that whole process as a key priority in the health sector and how that then translates to the health financing system. And also in Uzbekistan about focusing back to equity and financial protection. So at the end of the day, what is the goal that we want to achieve in addition to having that access to better quality services, but reducing out-of-pocket payment, reducing financial hardship for people. And then with our panel discussion, we had a really wide range of topics, and I think it was very interesting that we highlighted a lot of the key issues, and again, a reminder of some of these enablers: data governance, structure, consistency, how we apply models in the different contexts and situations, especially in low resource settings. Some of the emerging areas of work that we're seeing in countries in Nepal, Indonesia, China, and the Philippines, and how to manage across not just this wide and diverse population, but remote areas, using different models, and ways to collaborate. So how can we then share, like in this setting, be able to share experiences, but go beyond that, which I think we've already had some great discussion, and it's a warm up, I think, to the last session of the forum in thinking more, what can we then do together based on this, and what are the next steps? So I'd just like to then thank again and really highlight that, you know, there are diverse, definitely countries are working towards using AI in health, in health financing in particular. A lot of it with health insurance and trying to strengthen the strategic purchasing function. And then at the end of the day, linking this, trying to get, I think, being able to monitor and link this to the evidence to show that what is happening is also improving the financial protection in population is a critical step, which I think still needs to, you know, we still need to develop further evidence in collaboration on that. But definitely sometimes going back to the basics with some of these enabling factors, as well as, you know, countries were not starting from scratch. So that was also a key theme, and to use AI to, you know, to lead to those better services and ideally better financial protection. So with that, I thank all of the speakers, the panelists, the audience as well, and of course, our team, Iris, Lei, and the whole team to support this session. So thank you very much, everyone.
May I request our panelists to please stand for our group photo. We'd also like to invite once again our virtual panelists to smile on screen as we take our group photo for session 6. And also our speakers, please, may we invite you on stage. You are our well-abled resource persons for our session 6. Dr. Rudy Kurnawan, could you please join us also on stage? We are really happy to see Indonesia's progress on health financing on AI. A warm round of applause again to our experts, our resource persons, and panelists for session 6. So while they're having their group photo, may I remind once again our participants to please keep their food stubs. We will be collecting that at the staff hub later. We'll have our lunch at the same place where we had it yesterday. And we will have a 1.5 hour lunch. We'll be back at 1:30 p.m. So that gives you time to not only network, but absorb the wonderful presentations we had from our speakers and our panelists. Okay, that wraps up our session 5 and session 6. We'll see each other again 1:30 p.m. here at the auditorium. Have a great lunch.
That's one of the... Yeah, but I'm even asking one more symbol. If you are used to you are even going ahead. Okay. On my question is my number of the same,